Neither the El Paso County Medical Society, its members, nor KCUS-TV shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Knee pain. It's a common complaint that affects people of all ages. It could be a result of an injury, or it could be a result of normal wear and tear just as all of us get a little bit older. It can literally suck the joy out of everyday enjoyable activities. And it's awful to say that, but it's so very true. How do you treat it? Or better yet, how do you end knee pain? That's why we're here this evening. We have some new technology here in El Paso, and by new, I mean within a couple of months. Just this past summer, Las Palmas del Sol has acquired the Navio system, and we have 3 doctors here with us today who have been trained on the system. 2 have already done several surgeries on the system, and it certainly is making the quality of life for many El Pasoans, Las Crucesans, Juarezans, much, much better. During this next hour, as we were talking about, we have 3 doctors specializing in knee pain and knee replacement. And as you know, this is a live program, so call us with some questions that you'd like to ask us this evening. It's 881-0013. We are also streaming live on Facebook, so go to Facebook and KCOS TV, and you'll be able to get some feedback there. You can actually ask some questions on Facebook as well. This evening's program is underwritten by Las Palmas del Sol Healthcare System, and we also want to thank the Texas Tech Paulo L. Foster School of Medicine for providing the medical students here who answer the phones, who take down the questions and bring them our way to the docs. And a huge thank you to the El Paso County Medical Society that provides the show to you each and every month. I'm Catherine Berg, and you're watching the El Paso Physician. Thanks again for joining us. Again, I want to introduce the 2 medical students that are answering the phones here this evening. They're from the Texas Tech Paulo Foster School of Medicine. They're both in their 2nd year, so they haven't dropped out after their 1st year. We have Erin Pines with us, and we also have Ugoji and her Erin Pines and Ugoji and Ibanama. See? There you go. And there's a nice wave. So anyway, these are the nice young ladies who are going to be answering the phones and taking down your questions, because the nice thing about this show is that it is live. And if you have questions, you can just call in with those questions, and we will do the best that we can to answer them. We have 3 orthopedic surgeons with us here this evening, and we all have issues. I think after the age of 30, I'm going to say, we all have issues with the knee. And then people injure their knees prior to that too, but I'm just thinking that wear and tear. But we have Dr. James Bean with us again this evening, and again, orthopedic surgeon. We have Dr. Jose Diaz-Pagan, orthopedic surgeon. And we have Dr. Edgar Fernandez, orthopedic surgeon. So on that note, I was trying to have some fun with you all earlier, because sometimes it's different doctors, and you guys are all the same thing. So tell us about your firstborn, where you met your wife. I'm just kidding. Just give us a brief background about you being in El Paso and practicing in El Paso. Dr. Bean, you get to go first? Okay. You do get to start. Yes, sir.
Well, actually, I'm an El Pasoan. I grew up here and attended UTEP and medical school in Galveston and orthopedic training in Galveston, Texas at University of Texas Medical Branch, and did a fellowship in Dallas after that for shoulder and knee reconstruction. And so I came to El Paso in 1988, and I've been practicing here ever since. And it's my home.
It's your home. I like that. It's our home, too. I like that very much. Dr. Diaz-Pagan, how about you?
Well, I'm not from El Paso. I'm from Puerto Rico. I was born and raised there.
Say Puerto Rico again.
Puerto Rico.
Very nice. See, nobody in the studio can say it the way you say it.
Well, I did my University School of Medicine, orthopedics there. Then I did a fellowship in San Antonio, shoulder surgery. Then went back, was a teacher for 7 years. Decided that I need to do something different, so I came to El Paso. For 4 years, I've been here 15.
No, you came to El Paso for 4 years. You've been here 15.
Yes.
Welcome back home.
Not planning to move away from here for a while.
No. Yeah, you're going to stay here for a while. I hope that's the case. Dr. Edgar Fernandez, how about you?
I'm originally from El Paso as well, so I'm from El Chuco. If people know what that is. But raised by a family of 5. I grew up on the east side of El Paso, and I went to Indian Ridge Middle School, and then Hanks High School, and that's when I kind of decided.
Oh, you went to Hanks? I went to Eastwood.
Oh,
you were our
we
rival.
might have problems.
Go Troopers! Exactly, exactly.
And then from there I turned into a Silver Fox, so I went to Silver Magnet is when I kind of got interested in medicine. Then I became a UTEP minor. Then I also migrated to the capital of humidity over there in Galveston and in my medical school out there. Then I went to Indiana University to do my orthopedic residency. Came back just about 4 years ago and have been practicing since.
You know, everybody who's anybody comes back home to El Paso. I like that. Thank you for being here. We're specifically talking about knee pain this evening. And the title of the show is Ending Knee Pain. Put an end to knee pain. And I think a lot of people are interested in that. I think this show is a show just like back pain, knee pain, shoulder pain. Everyone has it. You go up the stairs, you're like, okay, now my knees are kind of hurting. I would love, Dr. Bean, if we can start out with just the simplicities of, and let's not talk about injuries. Let's just talk about normal wear and tear and what tends to be the most common causes of knee pain.
Well, in our discussion today, talking about joint arthroplasty, it's obviously arthritis is what we're discussing for the most part, and that's loss of articular cartilage, which is specialized tissue in what are termed diarthrodial joints, which are joints where usually two bones come together.
I'm going to ask you to pass that model while he's speaking about this. Sorry, this is perfect timing.
And there's mating of the joint surfaces. They're mating of the joint surfaces. I move it over this way. And the articular cartilage is the tissue, specialized tissue on the end of the joints. And in this model is illustrating a normal joint, moderate arthritis, severe arthritis, and of course a joint replacement, indicating the wear and bony reactions that occur, which as cartilage wears, there's stress on the bone, it hypertrophies, so there's osteophytes. Hypertrophies means enlargement of bone, so there's osteophytes that form extra bone, and then of course associated with that is chronic inflammation as the cartilage is breaking down and the joint is trying to control this process, and there's swelling, pain, warmth, all the things that we see as progression of arthritis occurs. And so certainly other causes of pain in the knee, but in the sense that many of these causes, injury, genetics, being overweight, malaligned knee, all these different kinds of things are factors that produce progressive deterioration of a joint, and that ultimately allows us to do reconstructions of those joints with materials such as metal and plastic.
And we're going to talk a lot about different materials this evening, and we're going to talk about a system or a way that surgeries are done. What I'd like to do, though, first, and I'll talk to Dr. Diaz-Pagan really quick, and the idea of arthritis in general, because I think a lot of the normal wear and tear, aside from injuries, and it's not an arthritis program, I get it, but are there some people that are more prone to arthritis than others? Is it something that runs in families? Is it because they did a lot of sports as they were young in general? How is it that when somebody's 50 that really didn't do football in high school or anything like that, or someone doesn't have arthritis until they're 60 or 70?
Well, actually, osteoarthritis is a syndrome, and it's a multifactorial syndrome. So many things are coming together, and the end result is having wear and tear of the joint. Malalignment, age, obesity, being a woman, heredity, family, they all contribute, and the end result is having an arthritic joint, mostly the knee. It's very, very, very common in this country. Half of all the adults in America will have arthritis of one knee, at least one knee, in their lifetime.
And is there a reason in America why that's the case, or do we know?
No, because that's the statistics that we know here. Okay. In other parts of the world, it's similar.
Interesting. Okay.
So it's the prevalence of osteoarthritis of the knee is immense. The statistics said that in 12 years, the amount of the increasing percentage of need for a knee replacement will increase by 600%.
Wow.
So
well, then I'm glad we're talking.
There's not enough orthopedic surgeons to do all those knees.
And everybody's living a little bit longer.
Exactly.
And so the quality of life is very important, because what used to be replaced back when you were 60, 50 years ago is very different than if you're 60 today.
But nowadays, half of the patients that need a knee replacement are less than 65. So we're seeing more and more young patients having the need for a knee replacement.
And I'm going to ask later too, and I know it's different for everybody, but how long they last. So just in the back of your head, know that that will be a question coming up. Dr. Fernandez, I'm going to ask you, even though we were talking about arthritis here, you're all orthopedic surgeons. So let's talk about, for your question, what are the most common knee injuries? And let's not talk quite about getting to the point of having to be replaced yet, but knee injuries that then will later on in life cause some issues.
Well, I think the most common one that I'm sure that everyone's going to answer is probably meniscal tears. And meniscal tears, guess what? The end result is going to be, and I don't know if the public knows what a meniscus is, but a meniscus is a C-shaped ligament in between your...
Feel free to use him, yeah.
Actually,
exactly.
I'll use that, the first one. So meniscus is a C-shaped ligament right in between your tibia and your femur. And it acts, if you can see it right here, it acts like a cushion to the cartilage. It has other functions such as stability and proprioception, which means the sense of knowing that where your knee is in space, as well as we think that it also helps shock absorber, and also helps feed the cartilage, if you will. And so the main function is shock absorber and also increased surface area to the cartilage. And so when that tears, which is a very common thing, you take away that cartilage, and it's difficult to tell a patient, well, when they ask you, is my knee going to be normal? Not really.
Right.
Every once in a while you can get a meniscus, but if we're talking about older patient, that's more of a degenerative tear, which means that most likely where it tore, it's not going to heal. And so it either bothers the patient and you treat it with medication and you see if it gets better, or you go in there and you try to trim it up to see if they get some relief from that.
Okay. So here's the question before going to replacements, because there are people that I had surgery on my knee, and it just kind of is thrown out there. So what does that mean, I had surgery on me? They're not saying they had a knee replacement or even a partial knee replacement, but when people say, I had surgery on my knee, most of the time, Dr. Bean, what might they mean when they say that? Is it meniscus repairs or?
Well, I would say yes, by far. Probably even more than joint replacements, there's many more arthroscopies that are being performed, and arthroscopy is a minimally invasive way to perform, say, a meniscectomy that Edgar was speaking of, and not only that, there can be localized injuries of the articular cartilage on the condyles or even on the kneecap that we can potentially patch with some cartilage implants now. The problem becomes is when this wear becomes widespread in the joint, that you're kind of losing the battle of trying to do less invasive things, and that's when the idea of joint arthroplasty comes up, is when you've kind of lost the battle and all the surfaces are worn. So the other factor, big factor, is ligament instability. When one tears a meniscus and they have an anterior cruciate ligament tear, their risk of arthritis skyrockets to, the last statistic I think I saw was up to 10 times the normal population. So it's a big factor, that instability, and losing a meniscus is quite detrimental to the knee, and leads us to do things in a younger patient. As a meniscal transplant, we can actually transplant a meniscus in to try to reproduce it.
I remember us talking a little bit about that last time, and that was fascinating to me. And so, again, and this is, maybe it's a plug for organ donation right now, but in general, there are so many parts of the body that as time goes by and research is done, that other people can use.
Right.
And I just think that was fascinating,
and
how that could be the case.
Orthopedic tissue is really amenable to transplanting because it's not real cellular. When you talk about bone and these, say, ligaments even, and meniscus, they're not real cellular, so there's not a lot of rejection or antigenicity that goes on. So it's really amenable to be able to be used as a substitute in this case of someone losing a structure. So there's a lot that goes on ahead of time in what we do, in addition to the end stage, which is a knee replacement. So we're not just out there doing knee replacements, we're also trying to preserve knees also.
Exactly. And I like the way you said that with the preservation of knees and just materials within the body in general. Dr. Diaz-Pagan, I'd like to ask you how some of these diagnoses are done. For example, and let's take a case study now. So let's now go back, because I'd like to start getting into the knee replacements and the system. So when is it time to have one's knees replaced? And that, again, different question for everybody, but if you can kind of just throw out, and I'd love for all three of you to think of some ways of answering that question. When is it time? You know, you've had so many issues, you've had years of pain, et cetera, et cetera.
When you have failed all modes of conservative treatment, including medication, injection, therapy, activity modification, walking aids, when everything else fails and you start losing range of motion, the pain becomes severe, that's when you have to consider doing a knee replacement, depending on the findings on an X-ray.
Okay. And on a simple X-ray, I say simple X-ray because there's so many other tests out there. On an X-ray, what is it that, and if you'd like to, maybe use that last model.
Actually, on this one, this is a normal knee.
Okay.
When you do a standing view of a knee, the thigh bone appears to be floating on the leg bone. It's not floating. What is occupying that space that you don't see anything, it's cartilage and meniscus. When you start seeing a decrease in that space, that means that the cartilage and the meniscus are deteriorating. You're losing it. It can be lost on the outside of the knee, on the front of the knee, and on the inside of the knee. So you will become either bow leg or have knock knees. And that's when you lose all the cartilage. What you see on an X-ray is contact between the bones. And that's end stage of arthritis. At that point, most patients, not all, most patients need something to be done.
Okay. Somebody mentioned earlier that women and men are different. It's just the formation of the hips and the knees. And so women have, and Dr. Fernandez, I'm going to throw this your way, and if you don't want it, throw it somebody else's way. But in general, just the shape of a woman, her hips and knees, how is that different from a man's? And why is the wear and tear different on the knees because of the male and female structure?
I don't know if more women are going to have a certain alignment, or what I'm trying to say is I don't think that you can just say alignment is an issue, but I do think it is more. I think more women do have what we call a valgus knee, which means they're knock-kneed and they're over. What's the word I'm looking for?
It's
an imbalance. It's a malalignment.
Right, a malalignment, and they're over wearing that or over pressurizing that compartment in the knee, and so the cartilage sees more pressure per square inch, and it starts wearing out the knee, and that's a cause of osteoarthritis, certainly.
Yeah.
And
there's also been some evidence to suggest that muscle development is important as well. Women tend to not have as because of testosterone, don't tend to have the same degree of muscle development and strength, and that may be a factor too in joint support.
Okay.
Yeah, and there is a muscle in the knee, in the inside of the knee, that in women is puny. It's called the vastus medialis obliquus, and that keeps the patella, the kneecap, tracking in the center of the thigh bone. And because the hips are wider, the muscles going into the kneecap are pulling not only up, they're pulling sideways. That creates a lot of stress on the cartilage on the kneecap, and that causes damage and chondromalacia, which is a bad cartilage. Eventually, that causes inflammation, and the theory is that over time, that inflammation will destroy the rest of the knee joint.
And this is also one of those pushes of trying to keep the weight down, because women tend to gain weight in the hip area, which again adds more stress to the knees. It's one of those secondary, third type things, but that's very important too. We're starting to really get some questions here from the audience. What I'd like to do, yes, Dr. Bean.
I'd like to answer one question that Dr. Diaz-Pagan answered earlier, because it's kind of interesting. It became somewhat of a personal issue for me. But when I came back to town, my dad had me take care of him and do his knee replacement, and
no pressure there.
Yeah, no pressure. So, but he said he paid for my medical school, so I had to do it. So anyway, he told me he was never going to have a knee replacement, and after 15 years of giving him shots and trying to convince him, he walked in one day and said, "I want a knee replacement." And so we did a knee replacement at 83, and he lived another 10 years with it and did very well.
You did a knee replacement at 83?
Yes.
And he lived another 10 years?
Yes, and he never had any more problems with his knee, so it was something I gave him and I felt very good about. But it was kind of interesting to me, the psychology is that when you do a knee replacement is when a patient is ready, and you're not going to do it before. And I don't try to convince a patient of that, tell them what they have, tell them what their options are, and they come to that conclusion. And I think it's better when they come to that conclusion themselves, because then I think they're in the game more.
And so when it's time, they know.
Correct.
Yes, Dr. Fernandez?
No, I think it's a very important point. I think it's a team effort. What I tell patients is you're a team member in the decision making, and a lot of patients will say, well, you're the doctor, but in an elective case, such as a knee replacement, I think they have as much say as we do. And I tell them, just like Dr. Bean does, all the options, and you tell them what can happen with those. We try those. If they don't, they're the ones that decide if they want to go forth with it.
Yeah.
I tell my
Nicely
patients,
said.
when they're very old and they're afraid, I tell them patients that need a knee replacement and have it live longer than those that need it and don't have it.
Yeah.
Because they become more active, they can do more exercises, they don't have pain, they don't have problems associated with pain like depression. So, yes, they have to, but you have to orient them and tell them, if you don't have it, your chances of getting better is zero.
Yeah.
I mean, just ignoring the problem will not make it go away. So if you're at a point that you're having horrendous pain, you can barely walk 50 feet, you popping pills and nothing is working, you have cortisone injections all the time and it doesn't work, like 15 years like that, well, that's when you need it.
Yeah, agreed. Let's talk about some of the options. I know we've got two options here on the table. Actually, let's first start with a partial knee replacement, because we talked about that a while back, and I think that was so interesting to some of our patients. The last model, is that correct? Is that a partial knee replacement? So, Dr. Bean, if you can kind of explain, what's going on here with this knee replacement, and maybe talk about, as we were earlier talking about the design options that there are out there and material options that are out there, and just kind of go through whatever you think can fit in, if that makes sense.
Sure. The idea of compartmental or partial knee replacement, most commonly on the medial side of the knee, is a procedure to reconstruct the surface of the knee. In this case, as long as the other compartments are pretty normal, pretty well. Maybe some very mild chondral changes can be present, but the real idea of this knee, in my mind, is, and it has been in the past until we now have a total knee that can spare the ligaments. This knee is able to spare all the ligaments that support the knee, and that's why we think it has performed so well. And so a lot of people that have this knee really like it. They feel good. They're what we call kinematics, or the normal little alterations in movement that occur as the knee goes through a cycle of bending and extension are maintained with this type of knee. And so that's why it's very popular. The only problem with this type of knee is that it doesn't have near the life expectancy of a total knee. Because you're only replacing one compartment, guess what happens with time? The most common cause of these to fail is odd compartment wear, which means either the kneecap or the other compartment becomes arthritic, and then you have to convert it to a total, because obviously there's no pain on this side, but it's hurting other places.
Right.
So these have a lower life expectancy of a total knee, but perform very well. So you just have to counsel patients, I think, very, very specifically about that, that they are going to probably, particularly if you've got somebody in their late 50s or early 60s, that they're very likely going to have another knee another revision or something else done to their knee in their lifetime. And I'd say that's the only glitch with this knee.
Okay. So let's talk about these two that we have on the table. I know that there's one, actually the way you were talking earlier, Dr. Diaz-Pagan and Dr. Fernandez, just feel free to chime in. Is this the latest and the greatest? Is that what we were talking about earlier? Okay.
The XR Journey.
The XR. The XR Journey. What a cool name. Okay, this is the XR Journey.
And this is recent.
Okay.
I think it took 15 years of research to arrive to this.
Okay.
And a lot of money. So they put a lot of, I'm not a paid sponsor of this, okay? I'm just saying, from what I have read, what I have seen, this is the most advanced knee replacement that exists nowadays. And the reason why it's so good is because it preserves the kinematics of the knee, the normal motion of the knee, by preserving the cruciate ligaments. Most total knee replacement, you have to sacrifice both or one. So the knee feels good, the pain relief is great, but the patients, and the younger they are, the more they tell you so. They say it doesn't feel like a normal knee. It's good, but it still doesn't feel like my knee. So
is it motion that you're talking about? The range of motion?
It's actually proprioception. They can't tell the position of the knee like they can tell if the knee was intact.
Okay.
By preserving the cruciate ligaments and the ligamentous structures, the proprioception of nerves of the anterior cruciate ligaments are preserved, so the patient feels like the knee is normal.
Okay.
As normal as it can be when it's a knee replacement. And for active patients that they want to continue doing an active lifestyles, and young patients, well, this is, if they meet the parameters that are specific for the use of this knee, it's a very good option for them.
Okay. Perfect transition to you, Dr. Fernandez. So now we're looking at qualifications.
I was also going to say something about the bicruciate retaining. The Journey XR is a new product. It's been around, the bicruciate retaining, which means we retain the ACL and PCL, has been around for a long time, since the 1970s. And they used to do it. Some had good results, but the problem was tibial loosening and also placement of the femoral implant. Over time, also, it was a very hard, I shouldn't say very hard, but technically demanding procedure. And now, with what we have, the Navio, the robotic surgery, assisted surgery, it's very, very doable.
Okay.
In someone who hasn't done many bicruciate retaining knees.
That is a nice transition, because I would like to start talking about the Navio. We do have a video, and I'd like to talk a little bit prior to us showing the video of what the Navio system is. So we have been talking about the hardware, if you will, and so now there is a new way, a new instrument to put knees in place. And Dr. Bean, I'll start with you. I know all three of you have been trained, and I understand there's two of you that have done surgeries with Navio, and there's still one that's going to be doing surgeries. But in general, what is different about this robotic system in the area, specifically since we're talking about knee replacements?
Well, in placing these implants, we have to have things that guide us on where to make bone cuts. We make the bone cuts to fit the implants in place, and the spacing between the femur and the tibia is important both in extension and in flexion. So, and those what they call gaps there's a extension gap and a flexion gap, and so traditionally we've tried to make those gaps equal with the more conventional implants that have been around, but it doesn't reproduce the normal kinematics of the knee. And so what Dr. Diaz-Pagan was referring to, a lot of patients that have a conventional knee replacement say, well, their knee feels better. A lot of the pain's gone, but it just doesn't feel like a normal knee. At our academy this last year, one of the big studies came out, a big multi-center study that looked at total knees over a couple of years. Was quite shocking. We were thinking that we're in the 95th percentile of patients getting well with these. 90% of the patients love it, but we actually found out that 21% of patients were not necessarily happy with their total knees. And so we think part of that is this break in the kinematics of traditional knees that is leading to these other things. The Navio system is essentially a computer robot assisted system to help us make these bone cuts rather than sticking rods up the shaft of the bone, placing blocks on that help us guide some of these cuts, and they're a little more rough. The Navio system allows us to make that bone resection more exact and more precise for both the fit of the implant, but more important also for the spacing of the implant and the balancing of the ligaments. And so that's what makes it stand out above anything else that's out there so far.
And it's exciting because, again, I understand, Melissa Offit, I have to give you a high five because I get a lot of my information for these shows before. And this is a system that came to El Paso in July, I understand. So all three of you are trained, and I think you two have done surgeries, is that correct on it?
Yes.
So with your experience after the couple of surgeries, I don't know, however, if you want to say how many surgeries you've done on it, but what do you find is the big difference or the high five for this system, so to speak?
For me is that you can actually see in numbers in a graph if the knee is balanced. If the soft tissues are balanced and there is no abnormal motion of the knee, that the gaps are equal and quadrilateral.
Right,
So
okay.
the space is exact and the tracking of the patella is perfect, and the motion of the knee behaves like a normal knee. You can see it and you can actually tell. You do it by feel. After so many years, you get good at it. But with this, it's a tool that makes you better.
Okay.
And makes you do a better knee with less invasive procedures, and you're not guessing, you're not just averaging the knee. Because what we do with the instrument is, well, we assume that everybody has the same anatomy. No, not everybody has the same anatomy. And with this, without having custom-made implants, which are prohibitively expensive, we can make a knee that looks and behaves almost like a normal knee.
And Dr. Fernandez, as this system is going forward, and let's just say now, knee replacements have been around for a while. Can this system also handle, or does it handle replacing old knee replacements? Is this something that the Navio system is also, I guess you can do that with any surgery, and maybe I can ask how common that is, that say knees that replaced, you were saying earlier, 10 years maybe, and your dad, beautifully, knee replacement at 85, lived to be, or 83, what did you say, 83 to 93? 83. But in general, to fix and or just replace an old knee that's been replaced.
So a revision
yes.
type of setting?
Thank you very much. A revision. That's the word I'm looking for. Yes.
Most certainly.
Okay.
Yeah, you can certainly use that, and I think they have the founders of that, or at least the first surgeons to utilize that, the robotic-assisted surgeries have been using them for some revisions.
Okay.
So yeah.
Mostly for transforming a unicompartmental, a partial knee replacement to a total knee replacement. It helps a lot. And still, I don't think it's still approved for revisions for full total knee replacements, but I think it's going to be in the future.
Nice. Well, what I'd like to do, and I think it might be queued up at this point, is see if we can get the video up. And Dr. Bean, if you don't mind speaking over the video, it's going to be a silent video, but we can explain to the audience at home what's happening during the video. And I know we're all looking at the screen, because that's a screen that we also look at, see when the video is queued up. There it is.
Okay, this is illustration during the surgery where we actually have a antenna system that's on the showing variations of checking the ligament balancing. This is illustrating the fit, getting the implant. That's another thing that this is system is very effective at, is we can get a very exact fit, and sometimes it's not always real visible to us, all the parts of the knee, say the femur, and this system looks at it completely through the navigation system and is able to predict what's the best fit. We can make alterations in shifting the implant forward or back or side to side, make small corrections that just make it more precise during the surgery.
And we have still graphics here with this as well, but it seems that the graphics that I have in front of me are the graphics that were on that screen too. Is that what these are from, or is this from an actual surgery?
This is from an actual surgery.
Okay.
And it's showing the different steps of mapping and then actual resection.
Okay.
And we actually use various burrs in the process of removing bone instead of saws. And saws can be imprecise. So when you make a cut with a saw, the saw can bend and have an effect on the surface.
Okay.
And where we find that with this burr system, we can make a better resection and say a more accurate resection before putting the implant on.
I'm going to ask Mario, who is our studio king in the back. Mario, if we can pull up slide number 5. I know that they're in different orders than what you have, but we're going to do a different order here. So if we can pull up slide number 5 in a few minutes and then let us know when that's ready to go. And Dr. Bean, I would love for you to kind of walk us through what we're doing. So we'll have number 5 and then have number 4 on standby. There we go. There's slide number 5.
Right.
And talk to us what
well, this is illustrating the part of the procedure. We've already got navigation points on the extremity. We've already found the center of the hip in a motion maneuver. So the navigation or the robot has picked up all of the points of the leg. We put points on the ankle, points on the knee, and of course the center of the hip. And so now this is the part of the navigation where we're mapping out the femur. Everybody has a little bit of different shape and size of femur. So this is helping us to map it out so that the computer is able to calculate the size, and then of course little fine translations that we can make of the on the computer system to make the balance better. In other words, we can check the balance of the extremity as we're proceeding through this.
Okay.
So.
And if we can cue up slide number 4. Which then would be the tibia.
Yeah, this is just mapping out the tibia.
Okay.
Again, preparing for resection.
And if we can now go to slide number 3, and then we'll cue up slide number 2 after that. So this is interesting here, yeah.
And this is illustrating our distal. The two main cuts that we have to make, the two most important cuts that everything else is off of, are the distal cut of the first cut, or the distal cut of the femur, the end of the femur, and the top of the tibia are the two most critical resections. So this is illustrating the resection of the femur. On the left, we've already resected the bone. On the right, you see the purple. That is the bone that's going to be resected by the burr. And the blue dot in the middle is a pin site that once we do that resection, we can actually make a hole at that pin site, and then we put another instrument on that makes the last cuts of the femur. So again, it's an assisted way to do this. Now this illustrates that we've resected all the bone. The little bit of red on there just tells us that we're a little bit more cut, the little bit of greens, a little areas where it's not quite cut. So it measures very, very, very accurately. And so the two peg holes are being made so that we put the final implant on.
And if you're able to go to slide number 1, this is an interesting slide to me.
This is illustrating the tibia, looking down on the top of the tibia. We get this illustration, and so on the left side of the structure of the bone there, you can see we've resected the necessary bone. On the right side is what's going to be resected next, and you see the white block in the middle. That's going to be retained because that's where the cruciate ligaments attach. And this is an XR knee, and then in the center there you see a line or a groove that wraps around. That's actually where the fin, or there's a little bit of a stem on the implant. They'll allow for rotational stability. We have to resect part of that for that stem to fit down in there during the fixation process.
Wow.
And it's really cool.
Yes. Slide number 8 and then 7.
It's really exciting and cool the way the robot actually works. So it's a drill bit that you can have it on 2 modes. You can have it on one mode where it actually telescopes in and out to allow for depth, and once that depth is reached, it stops on you.
Stops automatically, so it knows when to stop.
Yeah, or you can have it on high speed where you burr it all out, but once you get out of that boundary, it stops. So,
Okay.
yeah.
It's a
Interesting.
precision of about a 1 millimeter.
And I'm gonna, and Mario, just in a few minutes, I'd like to play that video again, because sometimes when we play the video and you're washing dishes at home, it's like, man, I just missed it, because I'd like to see it again too. But if we can throw up slide number 8 for a minute, and then slide number 7, then we'll be done with the slides, and then whoever would like to talk through this, there's...
The good thing about the procedure is that you can do the surgery before you cut bone.
Nicely said.
You do
right.
the surgery, it's a virtual surgery. And once you you calculate the sizes of the prosthetic components, the positioning, the depth of the cuts, it will give you a graph, and it will tell you what are the tensions of the soft tissues in flexion and extension. You have to do that by feel without this. With this, you can do the whole surgery without cutting bone. So once you achieve the level of balance that you get, you know it's correct, and you learn to trust the machine because it's always right.
Right.
And you make the cuts, and what you see at the end, you corroborate by moving the knee, and it matches what it predicted it was going to be.
I bet this is fun.
It is fun.
I mean, I can just imagine practicing this, and then when you're actually putting it into play, how fascinating that must be. And slide number 7, that will be our last slide. I don't know if they showed that. I was paying attention to you all. They may have put that back up. So that's the ending. And then I know that there's measurements and balancing over the last couple of slides. But I'd like to, again, if we don't mind, before we start running out of time, is let's play the video again. And Dr. Bean, you're welcome to talk over it or not. But now that we know a little bit more about it and watching it again.
Well, the actual machine there you see on the left is the Navio unit, and it has essentially a receiver that picks up information from the antennas that are on the patient, and a wand that we use to mark points. And again, this is illustrating being able to test the ligament balancing. This is illustrating sizing the implant and the little fine positioning of the implant. This is illustrating in this technique, instead of using the burr to make the distal cut, you can actually place some holes if you like using a saw better. This device attaches on and allows you to make a cut more traditionally with the saw blade instead of with the burr. But like Edgar said, it's a lot more fun operating the burr.
Yeah.
And it knows when to stop, so that's good.
And there's always human error in everything that we do. And every now and again, I know sometimes, I remember when the robotic systems in general were just being introduced to the medical world, and everything, oh my gosh, I don't want a robot operating on me, but it's not about that. It's about the precision. And I remember the first time I went to go witness before doing one of these shows, a doctor was showing me a suture and how his fat fingers, and I'm saying that because he said himself, look at my fat fingers trying to put together a suture, and I think he was doing, I don't know what he was doing, I think it was, I'm not even going to try. But then he showed me the way that these little tiny, if you will, these little clips were then putting together sutures, and how precise they were and how clean they were, and there was less room for infection, et cetera, and then you start getting it, that there is a reason that everything that is assisting you is really assisting the doctor, and that's so important to say. I've got a ton of questions here from the audience. I'm just going to start shooting them out to whoever wants. Dr. Fernandez, you haven't talked in a while. No, Dr. Diaz-Pagan hasn't talked in a while.
Can I say something
Yes,
real
you
quick?
can, absolutely.
So in this robotic assisted surgery, it really is assisted by the robot. It's not driven and done by the robot. The surgeon still has control of how they're going to be balancing out the knee, and so it's not like we close our eyes, we let the robot make the decisions that it wants to. We have to still use our knowledge to balance out the knee correctly. So.
And that's what people want to hear.
Yeah.
I think it's exactly what people want to hear. Dr. Diaz-Pagan, can a person with a history of osteoporosis recover from a knee surgery? And let me give my disclaimer, this is all the information that we get from the audience, so we do the best that we can with what we've got. That's why we have the disclaimer at the beginning of the show. But yeah, that's the osteoporosis, and maybe we can talk about the complications of osteoporosis in replacement surgeries.
If osteoporosis was a problem, I would do probably 10% patients only. I mean, osteoporosis is not a contraindication to do a knee replacement unless it's so severe that the bone will not sustain the implants. And the majority of the patients, osteoporosis is not a problem.
Okay. Question here from, and I love this one because this has nothing to do with the show, really, but can the doctors reintroduce themselves, is the question from the audience. So somebody's got a crush on you guys. So Dr. Bean, we're starting with you. Who are you? What's your name, sir?
James Wesley Bean.
And what do you do for a living?
I'm a bone doc.
I'm a bone doc. Nice.
You mean my background?
No, actually, I think they just wanted to get
Okay,
names again.
very
So, I'm not even looking at first names.
I'm with Sun City Orthopedics.
There you go. Okay. Jose?
Jose Luis Diaz Pagan.
Okay. And what do you do for a living, sir?
I'm an orthopedic surgeon.
There you go. And Dr. Fernandez?
And Edgar Fernandez, an orthopedic surgeon.
Thank you. I've never had that question before in my life, so I kind of like that one. I just had to honor that one. Question here from the audience. I'm going to throw it out. The doctors mentioned preserving the ligaments. Why is that necessary? Why not just put an artificial ligament into the knee? Question from the audience. Who wants it?
The ligaments are not only collagen. It's not like a rope inside the knee that keeps the bones together. The ligaments have blood vessels and have nerves, and they have a function, and the function other than stabilize the knee is to give information to the brain through the nerves on the position and the forces going through the knee. So the ligaments are very important. You cannot put an artificial ligament because it will never restore the proprioception of the knee.
And the other factor, mechanically, a ligament has a certain amount of ability to repair itself. It's a living tissue, and if you cyclically load a structure that's not living, and to the loads that we see in knees, it very likely will fail. So just, in fact, there was at one time an artificial ligament called a Gore-Tex ligament that was made out of Gore-Tex, and it found out that they failed miserably because of the cyclical loading in the joint. They were using it for an anterior cruciate ligament. And so, no, ligaments are remodeling, they're living tissue, and as Dr. Diaz-Pagan said, they have nervous input that's important too.
Right. And anytime you can preserve something in the body, do. Dr. Fernandez, we talked a little bit, so partial knee replacement or double knee surgery, this person on the phone had one in 2006 and had another one in 2008. I'm experiencing chronic pain at the moment and would like to know what might be the next steps for me. So again, this is not a lot of information. Don't know if it's the same knee, but again, one in 2006, one in 2008. We're 10 years later. So what would your best advice be?
So it's very difficult to give advice like that over the phone. I would say to go see his orthopedic surgeon to evaluate the knee, as it was done a long time ago. There's multiple reasons why a knee might be painful. Loosening, infection, low-grade infection is something that you really need to rule out in painful knees. It might just be painful knee or tendons around the knee that might be painful, not necessarily the knee. And so I'd say go see your orthopedic.
Yeah. An unbalanced knee.
Yeah. Question here from the audience. I hope I'm reading this right. If a patient has a broken hip and femur, how long should they wait before getting the knee replaced? So let's say somebody broke their hip and femur. Maybe they're waiting around for that to heal. Is there, and I guess that's a loaded question too, right? And we may not be able to answer that, may not even be close to answering that. I guess there's so many factors in there. And Dr. Bean, since you giggled, what factors are we looking at here?
Well, the question is the fracture healed or not healed? Certainly, that's a good question in the sense that you can have malunited fractures that can be a real problem in joint replacement. And in some instances, you might actually have to do a corrective osteotomy to get say a femur in more of a proper alignment with the limb before you can do such a thing as a joint replacement. So there can be some wild deformities there that are very specialized, and I would say doesn't fall in the norm of what we see with the majority of people coming in with arthritis.
Okay.
Also, if a patient have a hip fracture and it has hardware, and it's in the proximity of the knee, and the patient needs a knee replacement. The Navio is a perfect fit for this because you don't have to stick anything inside the canals of the bone.
Good
so
point.
it can also compensate for deformities of the bone. So yes, it can be done if the fractures are healing in a acceptable position. With the with navigation systems makes that a lot easier.
Interesting. Nicely said. Another question from the patients on the line. If a patient cannot be operated on due to obesity, is there any other intervention that they can seek? Since the knee pain itself makes it difficult to lose weight, is a question from the audience. But in general, this being fit for surgery, I guess, is the question here. Anybody want to take that one? Dr. Diaz-Pagan?
Well, the problem of obesity is that they carry a lot more risk, cardiovascular risk of infection, risk. They don't usually carry risk with the implants because they usually do well. But trying to do a surgery in a patient that has a BMI of 50 and her thigh is almost as wide as me, it's very hard to get down to the bone,
Right.
and it has a lot of problems. Patients that for any reason they have any contraindication, absolute contraindication for surgery, including excessive obesity. There's other things that can be done, but it's out of the scope of this discussion. But not everybody needs a surgery to feel better. I mean, it's not as good as a knee replacement, but there's other procedures that pain management doctors do that help the patients.
Also to that issue, there's such a thing as losing weight, and there's bariatric programs that that doesn't necessarily mean bariatric surgery, but a lot of those programs will have patients start off on better lifestyle activities and eating, and can allow that to improve to a point, and I've had that happen before.
Yeah.
So. And then, of course, in failure of that, bariatric surgery is available, and I've had a situation that's been successful too. So, so there are things that can be done, but it requires commitment.
It does. We are at about a 5-minute mark. I told you we'd stop earlier, but it happened so fast, and there's so many great questions. But before I continue with these questions, is there anything that we haven't talked about yet this evening that you all really want to get across before the show ends? And I'm throwing it out. Dr. Diaz-Pagan is like, he's in the Matrix right now. Look at him. He's like, let me think this through. So, Dr. Diaz-Pagan, you get to go. Is there anything that you'd like to touch base on, that either that, or if we've touched base on something that you really want to talk a little bit more about?
Well, about the Navio, I've been observing this technology. The first time I saw Navio was called Blue Belt, and it was version 2.0, and I did not like it. I thought that it was not ready. I observed it over the years, and now it's version 6.0. And I know it's going to get better. I don't know how they're going to make it better, because so far it's fantastic. I mean, of all the navigation systems that I have used in the past, this is the best. And it makes my life easier. And I can perform surgeries with a very high degree of certainty that I'm trying to do the best I can for the patient. I'm getting the best I can for my patient.
And I love the navigation system. I like the wording of that. I was trying to look for that wording earlier. Dr. Fernandez, anything that we haven't touched base on yet you'd like to talk about?
No, I think the Navio, what you want is an accurate and precise way of doing surgeries, especially for knees, because as we heard, not everyone's satisfied with their knees. And so I think it allows surgeons to utilize these tools so that we can precisely and accurately reproduce these results and get a good knee out of every patient.
Get a good knee out of every patient. Yep. I like that. Dr. Bean.
Well, I think you can see we're all in agreement and excited about this, and it's good to have colleagues that are doing the same thing, and we can talk about our experiences, and it's exciting times.
It is exciting times. On that note, I have a question very specifically for you, Dr. Bean, because of you and your dad. Question from the audience. Is it too late for a 90-year-old male with osteoarthritis to get a knee replacement? Again, loaded question. We don't know a lot of information, but I'm throwing that to you.
Well, I'm sure there's going to be a lot of opinions among the orthopedic community about that. But I would say, and actually this happened to me several years ago. I had a 90-year-old gentleman that was walked every day, was fit, had no active medical illnesses, was on no medication other than an aspirin a day, and had a bad hip, and he was miserable. So I did a hip replacement on him, and I know he lived 8 years. I don't know how much farther he lived past that. But, you know, he came back 3 months later, was happy as can be, and he's back walking again.
Right.
So I don't think you can ever say ever or never in this. And so you just have to weigh all the factors involved in someone's health.
Beautifully said. Question from the audience. We have very little time, but, and this is an old term, I was born with knocked knees, is what the patient says on the phone. I am 65 years old and wants to know if it is possible to have any knee replacements. And again, we have very little information.
Yes.
Dr. D, okay, Dr. Yes, that's, yes. So on that note, 20-year-old, should I worry if my knee pops when I stand after I've been sitting for a while? And we haven't talked about knee popping at all. Dr. Fernandez, you're looking at me with a smile.
No, so
we
it's
have very little amount of time to talk about that.
It's a very common complaint, and it's usually under the kneecap where a lot of patients get a lot of grinding and popping. It almost feels like a sandpaper type of feel, and it's usually some degradation of the cartilage.
Okay, so he's 20. Should he be worried about that?
I would probably get examined.
Probably get examined. Question from the audience, can severed ligaments be permanently reattached? Question from the audience. You did the Spock eyebrow. Dr. Diaz-Pagan, now you have to do that on camera. You did that a couple of times before the show, too. It's like, that's an interesting question. Let me give you my eyebrow. But again, question is, can severed ligaments be permanently reattached?
Some of them can be repaired.
Okay.
And they will heal, but ligaments don't heal with ligament. They heal with scar tissue. The ACL doesn't heal. Mm-hmm. The MCL, the medial collateral ligament, can heal, and it can be repaired, and it heals.
Yeah.
But it never heals with the same quality of tissue as the original, as the nascent tissue. So.
Okay. Nicely said. I'm sorry, we've got like 40 seconds, so I want to say again, thank you, Dr. Bean, Dr. Diaz-Pagan, Dr. Fernandez. We've been streaming live on Facebook. You can watch it again. You can also watch the show again on kcostv.org and on EPCMS, which is the El Paso County Medical Society website. And please know that Las Palmas del Sol Healthcare.com. There is an end knee pain seminar in English and Spanish in both September and October. But again, just remember Las Palmas del Sol Healthcare.com. I'm Catherine Berg, and you have been watching the El Paso Physician. Good evening.